Good morning, members. It is the appointed time and we have a quorum. I call to order the meeting of the Bills Committee on Electronic Health Record Sharing System Amendments Bill 2025. This is the second meeting. Now, we will now invite the administration to come in. Since the previous meeting, the Secretariat has issued the following papers to members. A. Follow-up matters of the previous meeting. That's papers CB brackets 3, 608, 2025, 01. And then the government's response. That's papers CB brackets 3, 608, 2025, 02. Also, the administration has responded to the letter sent by the Assistant Legal Advisor dated the 16th of April 2025. The reference number for the reply letter is CB brackets 3, 608, 2025, 03. So for the paper titled the amendments, bill, there is a typo. That's paragraph 2, starting with cap 6 to 5. So the corrected version is all private hospitals. So besides these three papers, the Secretariat has put up a notice on the website inviting public submission on the bill. The deadline is 5 p.m. today. The administration will be invited to give a response to the public submission. Now all the officials are seated. I will now invite the government official to walk us through their reply on the follow-up matters of the previous meeting. That's paper CB brackets 3, 608 brackets 2. Now concerning the letter sent by the Assistant Legal Advisor dated the 16th of April, according to the administration will walk us through their reply during the clause-by-clause scrutiny. Now, administration, please. Mr. Sam Hui. Thank you, Chairman. Good morning, members. Now I refer you to the paper and also our responses to the three questions raised on the previous meeting. Now for the first question, a member inquired of the scope of healthcare providers registered on eHealth. Now, in terms of the total number of eligible healthcare providers who are eligible for registering on eHealth, we don't have a figure. The reason is that although we have a clear picture of the number of private healthcare providers in the field, such as RCHEs and clinics, for private healthcare providers involving in non-medical services, for example, residential care services, if they engage professionals to offer services, they will also be eligible for registering on eHealth as healthcare providers. So these are not conventional healthcare institutions, and we don't have a clear grasp of the number of such healthcare providers in the market. However, according to the Labor and Welfare Bureau, they do have a number of such service providers of scale in the market. So we are confident that most of these healthcare providers, including operators of RCHEs, have registered for eHealth, but we don't have the actual figure. The second follow-up item At the previous meeting, a member asked, when the bill is passed and when the Commissioner for Electronic Health Record is empowered to require a healthcare provider to input data into eHealth, then we may need more manpower to follow up on complaints and follow up on investigations or even issue penalties. As I said, at this moment, we don't have an estimation for the additional manpower needed. There are two reasons. One, we are not sure whether the power would be invoked in the short run. Two or 3 years into the eHealth Plus program, we will consider whether the conditions are mature for the Commissioner to invoke this power. So it is too early to say whether we have enough manpower at this moment. Second, when we decide to invoke this power, we still have to decide how wide the scope of data would be. If the scope of data required from the healthcare providers cover the 5 major categories we mentioned in the previous meeting, then we may have to deal with a large number of cases. However, if the scope is limited and if the scope is limited to vaccination record and so on, then we will need fewer staff to input the data. So we will consider the manpower matching when the eHealth Plus program has progressed more, and also when the scope of data is decided. So to give you an idea of our manpower's establishment, we have provided information about the staffing of the Electronic Health Record Office to members. There are 6 staff members and 9 outsourced staff members in the office. So we will work on that number. When there are more inquiries and follow-up actions are expected in the future, we will increase the manpower accordingly. So that's the second follow-up item. The third item, member inquired about the situation regarding the purchase of professional indemnity insurance by private healthcare providers. Now, according to the professions, there are 2 types of insurance policies which are the most common one. Now, they are procured by the institutions where the professionals serve. So these would cover the liability incurred by the professionals serving in these institutions. Now, besides the liability insurance procured by the institution, there is also individual liability insurance policies procured by individual healthcare professionals. So the situation of indemnity insurances of these 2 types of policies are different in various professions. So the procurement of these insurances are driven by market forces. Now, members were concerned that the bill may incur financial liabilities on the institutions by way of penalties and court proceedings. Now, in terms of medical disputes and civil liabilities, these are common occurrences. So we believe that there are suitable products in the market for the private healthcare sector's need. Thank you. Now, before we resume the debate on policy matters, I would like to ask members whether you have any other questions concerning the replies on the follow-up matters. Carmen. Thank you, Chairman. I thank the administration for the reply. Now, you mentioned a typo, Chairman. That's on page 2 of the reply concerning the participation of private healthcare providers in e-health. Now, in the English text, all private hospitals have joined. In the Chinese text, however, only 13 private hospitals have joined. So which one is correct? Now, the administration is unable to give us the percentage of private healthcare providers registered under e-health. Because the government has been working on the basis of the total number of eligible private healthcare providers, including RCHEs. But my question was, the percentage of private healthcare providers enrolled under e-health. Now, according to CAP 633, please enlighten me, I'm a layman. The administration considers that most private healthcare providers have been covered by e-health. So is the situation ideal? There are all private hospitals and more than 3,800 healthcare institutions have joined e-health. They are not just healthcare institutions. They also include RCHEs and also social welfare organizations providing healthcare services. So the numerator is not clear. Besides, residential healthcare organizations and social welfare organizations What about ordinary clinics and public hospitals? I'm not talking about social welfare organizations and RCHEs, which also provide healthcare services. Now, patients should be able to make an informed decision. They need to know whether an organization is registered under eHealth. Now, EHS is also an important step in Hong Kong's healthcare reform. So I just want to ensure we have the same idea about the numerator. Now, the footnote mentioned another point. Now, as at 2025, some licenses or letters of exemptions have been issued to day procedure centers and other nursing homes. So what exemption is that? Is that an exemption for these institutions to register under eHealth? So can I have a reply from the administration first? Yes, I'll give each of you 5 minutes. So 13 private hospitals or all private hospitals? Thank you.
私家醫院
Private hospitals, the total number is 14. The member asked about the denominator. Depending on the members' interests, we can make the adjustment there. Even if we are talking about the clinics, the hospitals, the day procedure centers, and so on, the only area where we don't have 100% accuracy is the clinics. This is related to Ms. Cumming Khan's question. Under Cap 633, Private Healthcare Facilities Ordinance, the day procedure centers, the clinics of a certain scale, they need to make an application to be operational, but this ordinance has not fully come into operation. The only part that is in operation is the hospitals and the day procedure centers. As we mentioned in the footnote, in terms of clinics, we are going to be putting in place the registration system. But not all clinics have to register themselves. For the small clinics with very small numbers, they will enjoy an exemption. They don't have to make the registration. That they are getting the exemption. Exemption means that they're exempted from the registration. By dint of the exemption, it doesn't mean that they will not need to make available the information. So when the ordinance comes into effect, the exempted small-time clinics will also be identified. We will have the precise number then. So the small-time clinics under Cap 633 will not fully getting to grips with the precise number for the time being, because they may have a clinic in Mongkok, they may have another clinic in Hong Kong, and many a time they are not keeping all the information updated at all times. So by the time the application system kicks in, and that there are clinics that they will be exempted, by then we would have more precise picture about the number of clinics. In terms of service providers, we use the organization as a unit in terms of location. So later on, we're going to be having more precise numbers. Ms. Khan, I'm getting clearer now. Cap 633, there are certain parts that will not be kicking in until Q4 2025. By that time, we will have a clearer picture. Either you register or you get the exemption. Nobody would be falling out of the net. So for those who enjoy exemption, they will not come under 633, in particular small-time clinics. Now, the service providers are organizations. It doesn't matter how many premises they have. Let's say they have 10. Even for small-time clinics, they may have 2 separate premises in Causeway Bay in Mongkok. Now, however many premises they have, you count them as one single HCP. Is that right? That would make it easier because when they go into the e-health, they may have clinics in Mongkok or in Causeway Bay, and all of them will be connected with the e-health. Are you with me, Chairman? That there may be some large organizations that have a lot of premises, but even for a small-time clinic, one single doctor, they can have a number of premises. People may get really confused. I think the key thing is for all the premises to be connected with the system that would put my mind at ease. It doesn't matter whether I see Dr. Wong or Dr. Look. As long as I go to see them, I would be able to get access to my record, and they would have to upload the information by the time the legislation kicks in, and that would protect the patient's right to know. Care to respond? Mr. Hui? I think we are very similar in our thinking, whether we are looking in terms of premises or whether we are looking in terms of the professionals, that we would have the records. And Ms. Khan mentioned the scenarios that may not be totally applicable. In some cases in Hong Kong, one single premises would accommodate 2 doctors, and the other premises would accommodate different sets of doctors. So there may be a number of different combinations of doctors. They may be serving the same HCP. But as long as we get all the data, we would have the full picture. Right? Professor Chen? Sorry, Chairman, I'm running ahead of myself. I'm not on this point. Ms. Rebecca Chen, point number 4, Sam mentioned the existing, the number of staff in the existing electronic health record registration office, 6 staff members and 9 outsourced staff members. Now you're handling complaints and conduct investigation. I don't think this number is not good for reference, because these people are doing things and they would be different from what they are going to be doing in the future. So how can you extrapolate the future demand for manpower on the basis of these complement of staff? So what is the manpower projection is going to be like? Well, as the Deputy Secretary said, they don't have any manpower planning for the time being. Any supplement? Yes, Chairman, if I may add 2 points for members' information. First, we need to carry out investigation, but to a large extent, the nature of work would not be too dissimilar to what we are doing now. When it comes to investigation, by the time the statutory power is activated for the uploading of the data, then we should be able to have the back office data checking to verify the data. In fact, when we handle complaints, we are dealing with this as well. We are also dealing with the medical record, and so the investigation is not like the investigation by the law enforcement agency. It's a question of whether the access and uploading of the information would be in line with the requirements. But when the new requirements come in, we may need to have new additional manpower, and we may need to have training. I said we didn't have the precise number because we are not sure about the scope of the information that will be covered, because that would have implications on the demand for manpower. Ms. Chen asked me why we reference these present complement of staff. Now, given the existing level of manpower, we know the volume of workload that will be handled. We build on this and extrapolate the potential demand for manpower. So we work on the basis of this and make adjustment accordingly. So before we conduct the manpower planning, we just like to let members have some ideas about the basis on which we plan for the manpower level. So when we actually deal with the investigation and follow-up work, we will be increasing the manpower on the basis of the existing level, but we don't have the precise number for the time being. But this is only the proportion that we have in mind. Ms. Chen, no? Dr. Lam? Chairman, a technical question. If a service provider is suspended, the patient's record can continue to be uploaded. What if the qualification has been cancelled? Would that information be uploaded? Is it in connection with A? Well, this is about the reply to the legal advisor's questions. Sam? I defer to my colleague. Dr. Lam, are you referring to the cancellation of the registration, or are you talking about something else? With HCP, if the qualification has been cancelled in the e-health, maybe what they are doing is undermining e-health. Well, in that case, there will not be any uploading. Well, if the information is not uploaded, but the Secretary has issued an order for these organizations to upload the information. How do you reconcile that, Ms. Lam? Well, if there is risk pertaining to security, they cannot really upload the information. But we have to make sure that in the system everything will be secure. Dr. Lam. So if there is an enforcement notice, or will you be issuing the enforcement notice, Ms. Lam? What they have to do, try their best, and they will have to give a valid reason, a reasonable ground. We explain this further. Chairman, there are two scenarios there. First, let's not talk about the statutory uploading for the time being. Now, there is the power on the part of the Secretary to mandate the uploading of information. It can be the e-health users. It cannot be the e-health users. If someone is not a registered e-health user, there is an obligation to open the recipient's record for the information to be uploaded. It all depends on the scenario that you are talking about, Dr. Lam. If someone is the registered HCP, but because the system is not secure enough, registration has been revoked, then on the e-health platform, there is no way the information can be uploaded. But under the law, there is such a requirement. The HCP is a bona fide service provider as a non-registered e-health user. they still have the obligation to upload the information. So it all depends which scenario they fall into and what sort of defense they have. That may be technically because of the e-health has been connected, they cannot upload the information. If they have done their best, if they have done the due diligence and they still can upload it, that would be another matter altogether. So it depends on the different scenarios in that case.
一啲醫護人員佢可能係
Now, these healthcare professionals may be physiotherapists or clinicians. The computer systems may not be very advanced, and their firewalls may not be very protective. So what kind of due diligence are we talking about? How can we define that they have exercised due diligence? It is best to spell it out more clearly. Yes, the technical barriers. If the new power for the commissioner is to be invoked, non-e-health users may be required to input data into e-health. So in terms of technological assistance, we will ensure that the platform can receive the information submitted by the healthcare providers. So in terms of the defense, as long as there is a channel for uploading the data onto eHealth with reasonable efforts, then there will be a defense. Now, for very special scenarios where, despite exercising due diligence, data cannot be input, then that will also constitute a defense. Can I still ask a question on the follow-up actions? Now, follow-up item C. Now, according to Mr. Sam Hui, the secretary will be empowered to require healthcare providers to input key health data into eHealth. The scope will be specified on the schedule. Now, at present, there are 5 categories. So these are not on the schedule yet. Is my understanding correct? Currently, the schedule is empty. So from the administration's PowerPoint, we have learned that there are 5 prioritized categories of health data. In the future, the secretary will specify the types of health data which are important health data. So will the secretary specify the 5 types of health data in phases or in one go? Now, these include immunization record, medication allergy, and medical history, and so on, and radiology reports. And also, I think this has much to do with the insurance plans of patients. Now, the administration says that, according to the HA's policy, the HA would procure indemnity insurance plans for their staff. They will also offer legal assistance to the doctors. So it seems that the market force is at play here. Now, as a patient, we don't have much knowledge about the medical care we have received. So even if I want to file a complaint, I would be hesitant because we are not very clear about the diagnosis. And it is very difficult for a patient to file a complaint. So I think these are also points that we need to address in the medical reform. We need to be more transparent. Like the legal sector, under CAP 159, solicitors are required to procure liability insurance plans. So what about doctors? Is there a professional indemnity rule just like that in the legal sector and the accounting sector? 2 questions. Thank you. On the 5 types of critical health data, in terms of their importance, all 5 are of top priority. But we will be pragmatic. We will consider the level of digitalization in the healthcare sector in keeping these 5 types of health records. Now, in terms of immunization record, that is easy. Drug allergies and adverse drug reactions, that's more advanced. It depends on how well the clinics or the healthcare institutions keep the record. In terms of radiology reports and laboratory records and images, that is even more advanced. For smaller scale practices, they would usually have to engage a third party to provide these services. So there would be more difficulty. So all 5 types of health data are very important. But we will assess how ready the healthcare providers are in terms of providing these 5 types of health record. Can you give us a timetable? We expect that with the development of eHealth Plus, after 2 years' time, we will conduct an assessment on the readiness of the trade in terms of keeping these 5 types of record. However, for health data with less difficulties, we may impose the requirements earlier. What about insurance? So there is no legal requirement for doctors to take out professional liability insurance. In practice, essentially all practicing doctors would have procured professional indemnity insurance, despite the availability of an insurance scheme procured by their employers. But that is not a statutory requirement. Chairman, I think we have to keep it on record. Now, this is a very meaningful point. With a greater transparency in the healthcare sector, there may be more and more complaints and there may be more needs for indemnity insurance plans. So we will put it on record and we will consider the impacts on the trade after the passage of the bill. So there are no more questions about the follow-up item. Let's come back to the bill and the policy matter. Please press the request to speak button if you have any questions. Each member will have 5 minutes, questions and answers included. 3 members have pressed the button so far: Professor Chen Wing-Kwong, Ms. Rebecca Chen, and Ms. Connie Lam. Professor Chen Wing-Kwong, please. Thank you. This is a question from the macro perspective. There are 6.5 million patients who have registered on eHealth. Now, during COVID, eHealth was a one-stop platform for immunization and booking. So after COVID, patients are actually ignorant to the various functions of e-health. They don't even know what the sharing consent is. They have forgotten whether they have registered on e-health even. So after creating an account, how many accounts were not activated for a long period of time? And also how many accounts have given sharing consents? Second, I support streamlining the consent mechanism for health providers. But is there any measure to encourage the healthcare providers and the public to choose the streamlined consent pathway? Thank you. So the 6.5 million registrants, and how many of them have not used their account after registration? According to our data, there were some 3 million people who have created an account and downloaded the app. And among them, for those who have used the account, who have used the app and used the function over the past year, there were some 1 million population. We have been monitoring the trend, and we see that there is a general uptick in the usage of the app. The peak was during COVID because of the immunization program. So COVID helped us boost the number of registration in e-health. But there is a long way to go to promote general usage of e-health on a daily basis. As I said, there are some 1 million people who proactively use the e-health, and that is a satisfactory number. What about the streamlining of the consent mechanism? On streamlining the consent mechanism, under the present consent mechanism, first of all, the patients on joining e-health will give the joining consent. If the patient allows access to its health data by healthcare providers, and for them to update their e-health accounts, they would have to give the sharing consent. Now, under the streamlined consent mechanism, once a joining consent is given, the healthcare provider has the right or the power to upload health data onto the e-health account, but the ultimate decision on access will still lie with the patient. Now, under the design of the e-health app, a joining consent or sharing consent can be easily given. Ms. Rebecca Chen, thank you. First, about the cross-boundary sharing of health records. There are two parts. One is access to e-health by recognized non-local healthcare providers. Now, what about the other one? Connectivity with e-health by non-local record system. Does it mean that all non-local healthcare providers using that non-Hong Kong record system can gain access to e-health? Also, will the health records be kept on both systems, or will it be stored on a shared platform? Now, the bill uses the term connect, but there is no definition for connect. So should we define the scope of connectivity and also the extent of access? Third, if the non-local healthcare providers breach the terms of usage on eHealth, there is no way to take it up to them. The best you can do is to revoke their access to eHealth. So will there be more collaboration with the mainland authorities to ensure that our privacy protection for patients can extend to the mainland?
通方面嘅
The first two questions about the interface in connection with the non-Hong Kong HCPs, and the third question is about the breaching of the rule. Mr. Hui, the first two questions are related. First, we're not talking about putting the shared information on the same place. The mainland has their own medical data. In Hong Kong, we also have our own medical data stored in the eHealth system. It all depends on how the patients seek medical attention. We are sharing the information in that way. There is no question of contributing Hong Kong's medical data and putting them on a particular portal for access. The design is not like this. So that's why we are using this concept of connection. It is a transmission of data on a conditional basis, on a time-limited basis. We're not really sharing all the data in one single portal. Now we are transmitting the data, we are connecting the data, and we use the HCP as the basis. If a local HCP gets the consent of the patient, they can open the record. By the same token, non-Hong Kong HCPs, when they provide the service, the HCP can also open the record. But when receiving the data, there are two ways. First, the eHealth will connect with the non-Hong Kong HCP. So through this line, the information would be transmitted. So this is the recognized the non-Hong Kong HCPs. Second, if the non-Hong Kong HCP has a system which is similar to Hong Kong's eHealth system, then we'll be connecting with the government system outside of Hong Kong, and the health data would be transmitted to the HCP that way. So these two channels for transmission are intended to make sure that HCPs will get access to Hong Kong's medical data. So that's why we need to have the two levels of recognition. This is also related to the third question Ms. Chen put. Now, whether we are recognizing a non-Hong Kong system or a non-Hong Kong HCP, there is no guarantee that there may be problems and there may be misuse of the data. So we keep our options open here between on the government-to-government level when we're dealing with the sensitive healthcare or health data. We will have agreements entered into to govern the system, and we will have an agreement to cover the scenarios where the health data can be transmitted. And we are prepared to set up the liaison and enter into agreement with non-Hong Kong HCPs or systems in this regard. Ms. Chen. Well, the administration talked about a time-limited situation. Will the information be destroyed after access, or will the information be stored in their own system? Mr. Hui. Now, for the transmission via the e-health system, the non-Hong Kong HCPs will be able to open up the account, and they can also input the information within a certain time frame. And after that particular time frame, the interface will disappear. We do not allow the downloading function. They get access to the information. Doesn't mean that by the press of a button they will be able to store the data onto the hard drive. Well, but they can do a screenshot. You don't have the downloading function, but I can record it with my cell phone, and I can screen capture the information as well. Mr. Hui, well, they don't have to do that. Each HCP can get access to the health data, and they will look at the information that is relevant, and they will be jotting down the information and keep this as part of their clinical data. Well, they can jot them down if necessary. Ms. Chen. There may be patients going to the same clinic, and the doctor may wish to capture the information from the screen. Well, this is really on the wrong side of the law, but technically we can do this. You may not provide them with the downloading function, but for banks, you may not be able to do the screen capture. But I'm concerned about this for the system. I don't think they need to screen capture the information because there will be sufficient time for them to conduct the diagnosis. Mr. Hui. Well, if they need the professional record, they do have access to them. Ms. Connie Lam. I've got a question about support for the private clinics. There are some medical practitioners that said that with upgrading of the health system, their hardware and the software may not be able to cope. How are you going to be a system that we have earmarked $1.39 billion to upgrade the Health Plus? How are you going to render assistance? Many doctors are still handwriting their own medical records. If they have to input the information into the computer and uploading them, it might present difficulties. There may be a power conferred upon the Secretary for Health to mandate the use of e-health. So for the private practitioners, they express grave concerns. There may be some small and medium-sized clinics, they don't have a lot of manpower. If all the medical records, the radiological images, if they have to digitalize all this information, it would increase the financial outlays. Many of the practitioners are operating on a small scale. So do you have any financial support for these clinics to take full advantage of the health system? Because many of the private practitioners feel really deterred. Mr. Hui? Chairman, for the private clinics, small-time clinics, the extent of digitalization is not as high as the larger ones, maybe less than 20% of them. In this day and age, if they are not digital at all, then it is a rare situation. If they are not tech savvy enough, we may render assistance in different ways. Now, for clinics that are digital, we got the funding last year. Part of the purposes of the funding is to liaise with the providers to upgrade the system for the medical data to be uploaded using third-party solutions. We do now offer assistance there. But there has to be a digital interface to start with. If we're doing a good job there, as I said a moment ago, 80% of the clinics would have been covered. Now, for the remaining 10-20% of the clinics, it depends on the situation. If they're not digital at all, and if they have to fulfill the statutory requirement of uploading the e-health data, then they need to have a digital interface, or they may need to have a third-party team to convert the paper-based record into a digital record and upload this onto the e-health system. So when we are making preparation for the technical side of the equation, we will certainly do something about it. We hope that we will have some collaboration with the organizations in the industry. So for clinics that are less digital, we will be doing something about it. Ms. Lam. Well, there are some senior specialist physicians. They're getting on in years, and it's not the case that they don't have any computer system. But the fact is how much funding has been earmarked to assist them to upgrade the system. I'm sure that this is something that is exercising the minds of the practitioners. You said the medical records will be digitalized and put onto the health system. Will the medical practitioners be hiring more staff members to go digital? I hope that you will elaborate more on this. It's no good for you to pass the bill without thinking about this ahead of time. Well, this is about operational support in the day-to-day business. Mr. Hui, if we have to invoke the law, then the obligation lies with the service providers. That they may be uploading the information digitally, or they may be enlisting the help of a third party to convert the paper-based information into digital information. That's a procurement of service. If they have their own digital system, or they can procure technical system that will be connected with the e-health. But if they don't have any digital system, they can procure the third-party service that will convert the data digitally for uploading purposes. There is a lot of nitty-gritty that remains to be threshed out. I noticed what Ms. Connie Lam said, for those physicians that are more senior, It's not a question of making available the digital solution to them and expecting them to be able to do it. If they don't have the motivation to do it, it would be hard. And I'm sure that if we have the solution in the market, then for the least and digitalized clinics, we may not be able to offer them much. So there is a need for third-party assistance. So the third-party assistance, whether we can provide some resources to make this happen, we will certainly consider that. So when this kind of third-party assistance becomes available in the market, then the service providers can procure this kind of service.
請阿林志遠。
Thank you, Dr. David Lam. Thank you, Chair. I would like to follow up on Ms. Connie Lam's question. I can chip in here. Sometimes when we see veteran doctors retired, they will leave behind tens of thousands of health records. So sometimes they would issue a press release to invite their patients to take back their records. Or the records would be handed over to the successor. Then the doctors, who is the successor, would have a big headache. And the doctor need to get the consent from the patients again to use these health records. So following up on Ms. Connie Lam's question, a patient who has received medical care outside of Hong Kong by use of eHealth, will the record be automatically uploaded onto eHealth? If not, can the patient upload the PDF record onto eHealth themselves? I want to confirm how the recognition for non-local healthcare providers work. Both the non-local healthcare provider and the non-local information infrastructure need to be recognized for them to have access to eHealth. Is that right? Thank you. In terms of health record, when we invoke the power of the secretary, we will be very pragmatic. We will require doctors to upload all the historical health records they have, but we will be very pragmatic, and we may set a cut-off line in terms of the date. Now, in terms of interfacing with a non-Hong Kong information system, in the interface of the eHealth, there will be a function where non-local healthcare providers can upload health record on the eHealth. At present, even without that function, we do see non-local healthcare providers providing the digital copy of the health record to the patient for them to upload to eHealth themselves. So the last question from Dr. David Lam, whether both the non-local healthcare provider and the non-local information infrastructure have to be recognized. Now, a non-local healthcare provider can have access to the eHealth record with the patient's consent without going through a non-local information infrastructure. But that doesn't work the other way around. We cannot recognize an information system without the consent of the patient. I have another question concerning the autonomy of the patient in relation to the health record. They are the only one in charge of the health record. Now, if I decide not to upload the healthcare record on this occasion concerning a certain treatment or hospitalization, will there be a function for the patients to deny access for a single treatment? This question was asked at the previous meeting. Now, we don't have a mandatory uploading requirements according to the bill, so it depends on the interaction between the patients and the doctors. In the future, in case we invoke the power to require uploading of health data, the interaction between the patients and the doctor in terms of uploading data may prove to be an obstacle for meeting this requirement. So in the future, we will make sure that there is an option in the system for the patients to deny uploading of the health data by a certain healthcare provider. Now, that function must be transparent to the doctor. And it should clearly show whether there is an agreement between the doctor and the patient that the data will not be uploaded. Now, since the patient and the doctor have opted in, so that should be an opting out box in the system for the patients to deny access or uploading of a certain treatment. Yes, we will make sure that the design shows that some data has not been uploaded without showing the data. But if that health data is critical to the patients, the healthcare providers should advise the patients to think carefully whether to allow uploading of the information. Next, Ms. Rebecca Chen. Thank you. Now, the HA has always been the operator and the technical support for e-health. Now, medical health data is the most valuable data and the most sensitive data that the patient can give. So we need to reassure the public that there is proper maintenance and security safeguard for the e-health. Now, in the past, we have seen blackmailing incidents concerning sensitive personal data. Now, in the future, the HA will possess a large depository of personal health data. So how can we have confidence in the security of the system that we don't have to worry that our personal health data will not be leaked to criminals? Deputy Secretary. Now, e-health as a government information system, internally, we attach the highest security level to e-health. So in terms of hardware, software, and operation and liability, we have the highest requirements for e-health. Now, the major components of e-health is the data storage system for patients' data. So in the government's regime, the data storage platform is also a regulated platform which needs to meet statutory requirements. So in terms of actual operability and how to safeguard the data, I would defer to the HA. Mr. Eric Wong. Now, in phase 1 and phase 2 of the design of eHealth, we always understood the importance of data security. We prioritize data security in the design of eHealth. In the phase 3 design, more than 10% of the 1.4 billion funding allocated to us were dedicated to system security. There are two aspects. First, under the 5-year eHealth Plus plan, we have a program to step up security in terms of data encryption and data security. We are going to modernize our system and upgrade our system to fulfill the national and international standards. Second, as mentioned by Ms. Chen, there will be much more interfacing with the private sector. So in the systems design and also achieving connectivity with the private healthcare sector locally and overseas, we seek to achieve a higher security level with the private sector. Besides the HA, we need our counterparts to enhance their security standard as well. So in terms of knowledge sharing and awareness, as well as data and system security, the eHealth Plus 5-year plan has strengthened all the above aspects. Now, the Digital Policy Office has also rolled out a number of information security policies. The eHealth fully embraces these new policies in terms of hacking drills and so on. We have conducted a lot of testing. We have also engaged third parties to conduct annual checks on whether our systems are up to standard. These drills and third-party checking will be ongoing. Chairman, the HA said that it will help the interfacing partners to enhance their security standard, so it can be done for the local healthcare sector. But what about overseas partners? When there is interfacing, they will also be granted access to eHealth, so that may become a backdoor. So does the HA have the technological know-how to ensure security with them? Whenever we interface with overseas partners, we adopt the same security standard. So as we've mentioned, we will only interface with partners that are up to standard. We conduct safety audits for each type of health data, and also we have a standard for the formats of these data. We apply the same safety standard on them as well. And also in those overseas jurisdictions, there are also data security requirements in place. So we only ensure that we are working on equal footing. Mr. Holden Chow, thank you. I would like to follow up on the question of security assurance. Now, the reply was quite detailed. However, we are still pestering the administration about security because there have been numerous data leaks in government departments and semi-governmental organizations. The leakage were due to various reasons, including hacking. Health data is a very important type of data. When there is a leakage of these sensitive personal data, myriad of problems will be caused. For example, if there is a data leak of the health record of senior management in listed companies, it may affect the operation of that business. I'm just trying to bring your attention to the seriousness of this issue. Now, the government has said that it will do its best to ensure that there is no data leakage from their partners. But the thing is, it has happened more than once in the past. So despite the latest policies announced by the Digital Policy Office, can you make reference to the latest technology used by the country in putting up a firewall? We cannot neglect this risk. We don't want to be Captain Hindsight when there is a data leakage. We want to prevent any data leakage. So can you tell us about whether you have made reference to the firewall used in the mainland? Thank you.
副秘啊。
Yes, Security, Deputy Secretary. We are on the same page with Mr. Chow for the personal data, which is private. We have to tread with caution. As regards the software and the security, we adopt specific standards. We will be considering the mainland solutions as one of the ideas, and the DPO will also monitor the whole thing. If I may add one more point for members' information, with the e-health system and also the hospital authority system, Mr. Holden Chow talked about the firewall. I think we have to deal with this in two ways. If there is cyber attack on our system, Mr. Wong, I can let you know so many stories about cyber attack that is happening, that are happening on a daily basis. So we have to pay particular attention to our defense system against any cyber attacks. Second, the e-health system is somewhat different from the hospital authority system because e-health will extend to private clinics, old folks' homes, and so on. Mr. Wong referred to the security. We do have expectations on the users. But be that as it may, sometimes when things go wrong, it may not be wrong with the system. It is a problem with the human error in terms of procedure. So the second line of defense is, however secure the system is, if the end user, whether it be the old folks' homes or the clinics, if there are risks with their system, will we be able to defend the entire e-health system and to have the firewall kick in and will not allow the situation where the system going wrong affecting our own system. So we do have really stringent procedures. If things were to go wrong, how can we make sure that we can keep the e-health system secure? Ms. Carmen Khan, Chairman. Precisely, I want to raise the issue of security. I was chairman of the bill on critical infrastructure. Now, the bill, according to the administration, this ordinance will kick in 2026. The first schedule is about the healthcare service. And this is part of the critical infrastructure. The e-health system is an important system for Hong Kong. And I'm sure that this is there has to be a part of the critical infrastructure category. I'd like to remind the Department of Health and the Health Bureau to monitor the situation. You should be collaborating with the Commissioner for the critical infrastructure. And there are 3 obligations imposed on the operators. Like the Deputy Secretary said a moment ago, the Hospital Authority is the technical agent for e-health. According to the paper, it is the Hospital Authority that will be in charge of the technical side of things. And it will be providing the technical support. I know that there are third-party service providers employed by the HA. So the guidelines would have to ascertain the top-down guidelines and the requirements for the system, and that there has to be drills and contingency plans, and also there ought to be specific requirements to ensure security. And we have to make sure that members and members of the public will set their mind at ease. With the amendment of this ordinance, I think that it ties in with the coming into operation of the ordinance for critical infrastructure. And first, we have to monitor the third-party providers. Second, what is the relationship between e-health and HA Go, and would there be a further revision? All right, critical infrastructure in the interaction between HA Go and e-health. Sam, thank you very much, Ms. Khan, for the reminder. In the course of scrutinizing this bill, the Hospital Authority and the Security Bureau are also involved in the discussion, and we are fully aware of all the requirements. We will be acting in accordance with the law to make sure that the system is secure. The link between HA Go and e-health. Now, HA Go has a lot of users. As a clinical system, it is actually similar in nature to the private hospitals app. So the e-health covers the broad spectrum of data. HA Go is in relation to the specific procedures within the hospital setting. That the HA Go and e-health as a mobile app, we will try to minimize all the duplication between the 2 systems. Now we will have all the majority of the procedures handled in the health system. But for the hospital setting, if someone were to look for the time taken for the prescription to be available, they will have to go to the HA Go. But for the two apps, we try to avoid any duplication, but they will be existing side by side. And I'm sure that with more publicity and with the involvement of the e-health system, people will get to understand the distinction between the two. Ms. Connie Lam, I'd like to pick up on the issue raised by Ms. Carmen Khan. In terms of technical support, now HAGO and eHealth are supported by the Health Hospital Authority. We have to be judicial in the use of our resources. I'm wondering whether the two apps should be merged. We will be promoting a lot of primary health care services, and we can make appointments with primary health care physicians. If we can subsume HAGO under e-health system, then the public and private HCPs can use the resources that much more efficiently. We are talking about the same pool of users. I'm wondering whether there will be a merging between the two. The two apps are basically similar. The allergies, the doctors, the medical consultation over the past decade, everything is there. And resources are important. We have to economize. Sam? Right, in terms of resources, like Ms. Connie Lam said, at the back office, we have already done the consolidation. So the colleagues handling e-health sometimes don't know whether they are handling the HAGO or the e-health system. And we would try to consolidate the manpower in this regard. So in terms of system development and maintenance, if we can use the resources on either apps, we will try to avoid the duplication. So this has been done in back office. I appreciate what Ms. Lam said, but for the time being, we know that HAGO is in relation to the procedures for the hospital setting. If we merge the two, then a lot of the hospital procedures would be put into the e-health system, and that would make it less user friendly. Say, for instance, with HAGO, I can get access to the services provided by HA, like the time taken for the prescription to become available, and all the rest of the procedures. The hospitals would have their own software to render assistance. I think this represents a reasonable arrangement. Now, with this app, and there are a lot of referrals in the e-health system. How can we make sure that the whole system will be user-friendly? This is something we have to consider when we design the softwares. Like in terms of the appointment system, we try to put the appointment system in the e-health system because this would cover both public and private sectors. So one can make appointments, one can receive reminders, and this would involve a lot of the parties, including the HAGO. How can we make sure the interface would be seamless? And this is something that we have to consider. But conceptually, HAGO does have a function to serve. We try to have a clear distinction of work between the two systems.
大家
Do members have any more questions on the policy matter of the bill? Now it is my turn. I will be very brief. The question that was raised most is about how to render assistance to smaller practices which are not digital ready. So we really hope that the government would help them upload the historical records in clinics. But I think you need to give them financial assistance to engage services of third parties. So for healthcare providers who would like to join eHealth and also wants to convert the past health record into eHealth, I think help should be given to them. Another matter that was of members' concern was cross-boundary sharing of data. Now, for recognized healthcare providers and information system, there will be very stringent vetting, and also there will be a clear specification of the scope of data to be shared and also the duration of the interface. So there should be stringent safeguard against data leakage and hacking as well. So despite all these safeguards, in case of any inappropriate uses of healthcare data by non-local healthcare providers, our law cannot reach them. So we have to make it clear to the authorities in those jurisdictions what behaviors are unacceptable. We need to draw a red line for the usage of healthcare data by non-local healthcare providers. So one of my questions has been asked by other members as well. After the passage of the bill, we hope that all Hong Kong citizens will be registered in eHealth, and we should encourage them to use eHealth more. I think from the reference of other places, we should start with newborn babies. Now, can we bind the $20,000 newborn baby bonus with the registration under eHealth? We should adopt an opting out approach to encourage more people to register under eHealth and upload their health data onto eHealth. We should provide more incentives. Now, there may be some healthcare providers who are adamant in not joining the eHealth. They may even use it as an advertising point to patients. Now, sharing of health data and uploading data onto eHealth would be beneficial for the long-term health care for patients, and it would help avoid wrong diagnosis. But there may be healthcare providers who advertise themselves as institutions which do not upload data onto eHealth. So will there be more deterrence for these institutions? Now, the penalty seems to be insufficient to discourage such practices. That would hinder the progress of extending the coverage of eHealth to the entire population. So is the penalty sufficient? Thank you, Chairman. Concerning encouraging more people to register under eHealth, especially reaching out to newborn babies, that is also our priority as well. We are considering the feasibility of adopting an opting out approach. Concerning the Chairman's worry that there may be a peculiar situation where a healthcare provider uses its separation from eHealth as an advertising point. Now, we don't see this happening yet. Most healthcare providers support the concepts of eHealth, but we will monitor the situation closely. But besides legislative means, if claims made by healthcare providers are not beneficial to the long-term well-being of the patients, then we may take action. These are in relation to not just law, but also ethics in the profession. Now, if that happens, we will communicate with the regulatory body in the field. And send a correct message to the patients and protect their rights. Thank you. Now, in terms of professional ethics and values, will you work with the medical council to mandate doctors to advise the patients to register under eHealth in the first consultation? A standard script should be drafted by the medical council about the benefits of joining eHealth. Well, will you consider that route? Now, as the regulatory body of the medical profession, the medical council may consider that. Now, in relation to the development of eHealth and also new legislative requirements, the medical council may want to provide a standardized practice for the trade to require the doctors to explain the services to be provided to the patients. So we will sit down with the medical profession and formulate convenient tools by way of guidelines or directions to achieve this balance. Thank you. Any more questions about the bill? If not, we will proceed to a clause-by-clause scrutiny. Ms. Carmen Kan, Chairman, just one question. Concerning the question you asked on whether there will be healthcare institutions using this point as an advertisement. Now, the bill empowers the Secretary for Health to require healthcare data from healthcare providers. That includes healthcare providers who are not registered under eHealth. So whether the healthcare providers are registered or not, the Secretary can still require these healthcare providers to provide these critical health data to eHealth. So besides incentives, there is also this can also be made a statutory requirement. But according to the Deputy Secretary, I believe that most healthcare providers will be working towards the benefits of their patients. Thank you. If there are no more questions about the policy matter, we will proceed to clause-by-clause scrutiny. So we will use the Chinese text during the scrutiny. So we will invite the government official to take us through the blue bill. We will start with page C1086, the long title of the bill. Chairman, I will take the lead here. Thank you. We are now at the clause-by-clause stage. Please refer to the Gazetted Blue Bill, page C1086. So there are 60 clauses in 3 parts. The first part is the preliminary. The second part is about amending the relevant recognition ordinance and also technical and related amendments. Then we will proceed to the long title for the first 2 clauses, and then we will go back to the markup copy. On the 16th of April, the legal advisor has sent a letter to inquire matters about the bill, and a reply has been issued yesterday. Later on, when we come to the relevant part, we will go into details of the government's reply. First, the long title. Please refer to page C1086 of the Blue Bill. Now, it is a bill to amend the Electronic Health Record Sharing System Ordinance to rename the information infrastructure established and maintained under Section 5 of that ordinance to Electronic Health System, or eHealth System. To expand the purposes for which the eHealth system is maintained, to revise the scopes of health data, shareable data, and the consents under the eHealth system. To provide for the recognition of non-Hong Kong healthcare providers and non-Hong Kong information infrastructures for the operation of the eHealth system. To facilitate the use of electronic medical documents and invalidate certain medical documents that are not issued through the eHealth system. To require certain healthcare providers to provide certain health data to the eHealth system. To provide for matters relating to the provision and obtainment of shareable data by registered healthcare recipients and persons related to the recipients under the eHealth system. To expand the purposes for which data and information contained in electronic health records may be used. And finally, to provide for related matters and minor amendments. Any questions? Please continue. Part 1 Preliminary. There are 2 clauses here. Clause 1, short title and commencement. This ordinance may be cited as the Electronic Health Record Sharing System Amendment Ordinance 2025. 2. This ordinance comes into operation on a day to be appointed by the Secretary for Health by notice published in the Gazette. So to elaborate, the legal advisor inquired how we will deal with the commencements of the bill. Now, the amendment bill is to tie in with the developments of eHealth Plus. Now, in July last year, the Finance Committee has approved funding for the development of eHealth Plus. Since then, preparatory work has started. So most proposals in the bill are for providing a legislative framework say for example, empowering the Secretary of Health to require healthcare providers to upload health data to the e-health accounts of patients, and also to provide for the commissioner's power to recognize non-local healthcare providers and non-local information system to use the e-health and specified for electronic documents. And also there are proposals in relation to streamlining consents. Now these will come into effect after the passage of the bill, and we need to update the system and operational procedures of e-health subsequently. Now we're now preparing for the technical setup of the bill. Providing that the bill is passed within this legislative term and when the technical setup is ready, we plan to have the system commence within the year. We will continue to assess the situation, and where appropriate, we will move a committee stage amendment to amend the commencement date.
Please. Part 2. Enactment amended. The enactment specified in parts 2 and 3 are amended and set out in those parts. Let's move on to part 2, and that's the marked up version. CB3 541 stroke 2015 bracket 01. First amendment to the long title. With upgrading of the e-health, we are expanding the function. So we delete electronic health record sharing system and substitute an information infrastructure for keeping and sharing electronic health records for providing support in connection with or facilitating the provision of health care or health management. And the system, the wording will be deleted. Short title and commencement, part 1 preliminary. This is to rename the ordinance, electronic health system ordinance. So it's not confined to record sharing. This is going to be an electronic health information infrastructure. Turning to page 2, interpretation. This is to provide interpretation for the commonly used terms. This covers so many provisions, and this interpretation would be amended for certain definition. If members have any questions, we can further elaborate. First, we add 2025 Amendment Ordinance. So whenever a reference is made to this, this would be the reference. And the sharing consent. So we will amend the sharing consent. We will delete all the wordings following consent and substitute any other data information or in relation to a relevant healthcare provider means consent given under Section 12(1)(a), or in relation to a recognized non-Hong Kong public health record system means a consent given under Section 12(1)(b). And in B, we are referring to the non-Hong Kong public health record system. Erica, you follow the order, it would be easier. That's marked up version, page 0002. Will you follow that page, please? Sharing consent, is that okay? 0002 on the marked up copy, not the blue bill. Yes, we looked at the sharing consent, the amendment there, and in the marked up version, we've deleted the sharing system because we'll be using the e-health system. So this definition would be deleted, a technical amendment there. And there will be a definition for the e-health system. And shareable information, shareable data in relation to registered health care recipient means any other data or information of the healthcare recipient that is in the Commissioner's opinion necessary for the proper functioning of the e-health system. So this system will be, this information will be included. Any questions? Let's turn to page 3 of the Chinese version. Prescribed healthcare provider. We expand the definition there. We would delete or and semicolon, and after B, we add BA, the Primary Healthcare Commission, BB, a healthcare facility managed or controlled by 1, the government, 2, the hospital authority, and or 3, an HA subsidiary. So other than HA or DH, we have included all these different organizations to put things clearer. Any questions? Ms. Khan? Chairman. Well, for shareable data, a C is added. The data and information. And there is no amendment there, and they are in the original ordinance. What is the difference between the two? C, you use data or information. Can you elaborate on this, please? Yes, let's come back to the shareable data, the definition there. The original definition covers the index information and also the health data of the healthcare recipient. And further to that, we have added C, any other data or information of the healthcare recipient that is in the Commissioner's opinion necessary for the proper functioning of the e-health system. So the system will be generating certain information if there is a referral, and the referral would be part of the record. And we would include this kind of information into the scope of shareable data. So data and information, that's point number 1. Second, are they related to the 5 key pieces of information like allergies, history of allergy, diagnosis, and so on? Are they related to this? Well, shareable data, this can be shared under the e-health system. An HCP can share this with another HCP. An HCP can upload certain information, who will get access to the information. And this is a very broad definition. It would cover what Ms. Khan said, like the key information that the secretary can be empowered to mandate uploading. And this is the health data, Ms. Khan. So you don't need C for this to be done. Would the DOJ explain the difference between data and information, please? Yes, data, information. Chairman, thank you. Well, data and information, this is to tie in with 52C. In the marked up copy, page 13, now 52C, we're just replicating this paragraph into the definition of shareable data. Ms. Khan? So in this interpretation, I can't see any definition, anywhere, any definition of data or information. Is there any definition for data and information? The answer is no. So you would be interpreting this according to common sense understanding. Or in some cases, there may be a definition for those, but here you don't, do you? Ms. Tam, what information and data would be different in that data would cover a broader spectrum of things, and they're complementing one another. It's about time to end the meeting. Any further supplement regarding data and information? We bring the meeting to a close after this. Ms. Khan, well, I think we have, we'd like to put down a marker here. I'm wondering whether we need to have further elaboration on data and information. So the common sense interpretation may not be sufficient. So we do not take this as presented for the time being. I know that these are not interpreted there, but we put down a marker there. Any supplement? Well, for the prescribed HCP, healthcare provider, marked up version, page 3. Perhaps we pause here. If we carry on, we may be overrunning the time. Perhaps we pause here. We stop at 002, 003 on the marked up copy, and the definition of information and data. Let's see whether there is any further supplement next time. All right, thank you very much, Erica. Meeting is now adjourned. The date of the next meeting will be sorted out, and members will be notified of the date. We will carry on with the clause by clause next time. Thank you very much.